I am a senior researcher at the International Foundation for Integrated Care, IFIC, and I'm the head of Solutions. Solutions is a service we provide to organizations, to systems, to design, implement, and evaluate integrated care programs, services. And it's a real privilege for me, it's an honor, to be co-chairing this first session, this plenary one, with Professor Deirdre Heenan, whom I kindly invite now to present herself and welcome you all.
Thank you. Okay, good morning, everyone. Good morning, Belfast. Can I just say I am delighted that we've talked about this for so long, that we've brought this conference to sunny Belfast, and you're all absolutely so welcome to this city. It's my home city, so I can't tell you what a pleasure it is to have you here. And I know some of you have travelled very far to be here, and you will get a warm Belfast welcome. I have a confession to make. The weather that we had over the weekend isn't really what we normally have. I'd like to tell you that it is, but the sun was shining for this conference. And the other thing you know about people from Belfast and the north is that we like to talk. And you will know that part of this conference is about meeting people and meeting people that you might not otherwise meet. So I really urge you to walk up to people. We won't think it's strange. Introduce yourself and tell us about the work that you are doing. Because if there's one thing I know about care, healthcare and integrated care is we can all learn from each other. And the great joy of conferences like this is you can meet people and share the learning. My name's Professor Deirdre Heenan. I'm the scientific chair for this conference. I'm a professor of healthcare, have written widely about integration and healthcare systems. I am the Northern Ireland lead for a £15 million ESRC project on social care and integration. And of course in Northern Ireland we are very interested in the whole idea of integrated care because uniquely in the United Kingdom we have an integrated care system. So it gives me great pleasure to see you all here and see all your smiling faces, and we will endeavour to keep you engaged. No nodding off, no checking your phones. But the other thing I would say is I have a challenge for you. I want you to get our hashtag trending in Belfast. So you'll see it up behind. So for all of your tweets, make sure you use that hashtag, and then we will be the talk of the town, which is what we like to be. And it gives me great pleasure now to introduce our first speaker, who is Sharon Gallagher, and she's going to come and talk to us about the journey to transformation and integration in Northern Ireland. Thank you.
Good morning, everyone, and thank you to the IFIC board and the broader family for the invitation and the opportunity to be with you all today and part of this opening session of the conference. And good morning to you all here this morning. I am delighted that IFIC chose to hold this conference in sunny Belfast and extend to you all a very warm welcome, particularly those visiting Northern Ireland for the first time. It is a busy event over the next few days with many interesting sessions and contributions from the international stage and locally. I hope you all enjoy the experience and get the most from this brilliant opportunity to engage with so many like-minded colleagues and peers. By way of introduction, I am indeed Sharon Gallagher, Deputy Secretary with responsibility for the Strategic Planning and Performance Group within the Department of Health in Northern Ireland. With the support of my team and in line with Minister Swan's priorities, we plan and commission health and social care services for the population of Northern Ireland. We hold providers to account for delivery and for best use of the resources allocated by the government here. It is a broad remit, but a challenging one, and one that is hugely important, not just in what we do day to day, but critically in what we can do to help shape the future. And with that look to the future, we have been leading the work here in Northern Ireland on the development of our integrated care system, commonly known as ICSNI. I am delighted to have the opportunity to share with you our journey towards integrated care. And I'm equally keen to hear about your experiences and expertise as well. After all, we have come together in order to hear and to learn from each other. and to help each other on what is a challenging journey. This conference will allow all of us the opportunity to spend time with people who are dedicated and passionate in delivering integrated care in different ways, learning from other experiences, good and bad, to continue to strive in our endeavours. And there are excellent opportunities to find out what we have been doing in practice here in Northern Ireland, through site visits to some of our local programmes, as has been previously mentioned, or at the conference itself with a range of presentations looking at how integrated working is being taken forward locally, ranging from social care to primary care, secondary care, and with wider partners such as those in education or the voluntary and community sector. I am delighted to share the stage this morning with Professor Rafael Bengoa, who you will hear from shortly, and who I've had the pleasure of working with previously. Professor Bengoa is no stranger to Northern Ireland, as he led an expert panel for the department back in 2016, looking at our health and social care system. The report of that panel, System Not Structures, has been a significant driver for transformation here. I'm also looking forward to hearing from our other esteemed panel members this morning, Aku, Sarah and Johnny. Johnny has been directly involved in shaping our approach in Northern Ireland, and I thank him and others for their insights and contributions, which were instrumental in bringing us to our point today. Our integrated care story began almost 10 years ago in 2015, when a review of commissioning was undertaken by Sir Liam Donaldson. It found the commissioning process to be too complex, bureaucratic and transactional for a region this size. That led to the establishment of the expert, clinically led panel that I mentioned, with Professor Bengoa at the helm. I think it's Professor Bengoa's name that's putting me off kilter all the time. To consider and lead on an informed debate on the best consideration of health and social care services in Northern Ireland. That report found that we were not delivering against a population agenda, and we continued to operate in silos, with a need to move towards a more integrated model of care. The department's response to this was to set out, in delivering together, a vision for transforming services over a longer period. So in short, we had our context and rationale for change. We had expert advice on the way forward, and we had in place an agreed roadmap for how to go about it. Surely it would be plain sailing. Well, as we all know far too well, reforming a complex health and social care system is never simple and doesn't happen overnight. To compound that, in recent years, we have also been faced with some of the most challenging circumstances I think we have ever experienced. Not just because of the pandemic, but also because of the ever-increasing pressures and demands of our systems. And locally in Northern Ireland, we have had significant periods without our executive or political leadership in place. However, where there is challenge, there is also opportunity. And we have been pushing hard to make the most of the opportunity we have had before us. Over the last number of years, we've been working to make our vision of an integrated health and social care system in Northern Ireland a reality. And despite the challenges, I believe we have made significant strides in this regard. We have designed an approach that builds on the strengths and learns from the past. One such strength is the fact that health and social care in Northern Ireland is already integrated in statute. That puts us in a very different position from many other places. But it is also true that mandating integration, in other words, creating the policy position, does not in itself mean integration in practice. Integration does exist, but driven more, in my view, by individuals wishing to collaborate for the greater good, rather than an agreed and universal approach. What has been missing, as Professor Bengoa and his team highlighted in their review, is the strategic intent behind this integration. So we have taken that foundation and have looked to build on it, to develop an integrated care system that works for Northern Ireland. That has been our starting point for this journey in integrated care. As you will know, Northern Ireland is not a huge jurisdiction. Yet, we had found ourselves in the position where, in a way, we had overcomplicated our approach to trying to meet the needs of the population. Our structures were creating and enabling silos, not helping to break them down. This had resulted in overly bureaucratic governance arrangements, focusing on targets and not on outcomes. So we had to change the landscape in which we worked. A key enabling factor has been bringing planning and commissioning into the heart of the department, closing the Health and Social Care Board, which was an arm's-length body, to create the Strategic Planning and Performance Group within the department. This action served two purposes. Firstly, to remove the bureaucracy created by organisational structures, and secondly, and just as important, to support and enable the conditions in our system that allow for improved collaboration, clearer strategic leadership, and clearer accountability. But closing the Health and Social Care Board is a technical change, and whilst difficult, particularly for those impacted, it can be clearly project managed, understanding risk and managing change. Developing an integrated care system is a whole other thing. Change that evolves is uncertain and is based around culture and people rather than structures and hierarchies. So I oversaw a small team led by Martina Moore, who will be speaking later in the conference and is sitting in the front, to work collaboratively with our system and wider partners to develop a new model for Northern Ireland. And we recognised that to truly do things differently, we cannot simply look to harness the strengths of our health and social care sectors. We must also look beyond ourselves to our partners in areas such as the voluntary and community sector, local government, and our service users and carers. Therefore, we have worked in partnership with every part of our system and with those outside it to critically think about how we can and should plan and commission health and care services in a different way. It has been a significant undertaking and has demonstrated our commitment to change. And where we started is not at all where we are today. Our understanding through that collaborative working has evolved over time. It has allowed us to have a better grasp of what it is we need to do here, what will work, and what will be most effective. And it will continue to evolve. One thing we have most certainly learned is that there is no defined endpoint when it comes to integrated care. It is an ongoing journey to continually strive to improve things by working together. But I am confident that where we are going next on our journey is very much the right direction for us in Northern Ireland. ICSNI is a single planning system that will help to improve the health and well-being of our population and work to address the health inequalities that continue to exist. It will see the establishment of both local and regional partnerships and will place a greater focus on prevention, early intervention, and community health and well-being. These partnerships will bring that wide range of stakeholders with an interest or responsibility for health and well-being together to develop plans using their collective assets and resources, targeted at improving the outcomes for the population. Alongside these partnerships, we will be establishing multi-professional expert teams to support this new way of working, bringing that understanding of the current system and what good looks like based on evidence and identified need. And the thread through all of this will be the shift to working under a new strategic outcomes framework, which moves us away from a transactional, target-driven approach to one that is outcome-based and collaborative. Work is well underway, and we will be standing up in shadow form between now and the end of the summer. The model will ensure that the right people are working together to traverse boundaries in a much more effective way than we do presently, and to maximise the potential across this system. It will also see us improving how we assess our population's needs and ensure that what we do is what we need to do and that it is delivered in the best way possible. not simply do what we've always done. Whilst the model is developed, our success will come down to people. If we do not cultivate the right culture in which people feel supported and motivated to work in a more collaborative way, then we will fail. Through our development and implementation approach, we have placed a premium on engagement, modelling the way forward. Implementation puts a responsibility on all of us working with ICSNI framework to collaborate and to integrate. And I hear every single day, ICSNI will sort this, it will fix that, it will right all of our wrongs. If only that were so. It is not the magic switch that when we flick it all our problems disappear. It is not the end in itself. Rather, it looks to create the circumstances and the conditions that bring together those who can collectively come up with the right answers. And it is clear that integration will be a key enabler in supporting wider system transformation. It is one of the drivers in adopting a broader population health approach, focus, and supporting collaborative working within and across sectors. We know that if we want to improve our population's health and well-being and ultimately address demand, we must focus on prevention of ill health and early intervention, on keeping people well, and on optimising our effectiveness and efficiency so that when people do need our services, we are using our resources well to get the best possible outcome. ICSNI provides us with part of the solution to do just that. In finishing, I would like to leave you with 3 key points that I think we have learned so far in our journey in Northern Ireland. Firstly, the move to integrated care will be a continuous one. There is no set day that we will achieve integration. Instead, it will only be delivered through our ongoing commitment to this way of working on a daily basis. Secondly, it is not the answer in isolation. It is one part of the wider system of transformation that is necessary for us to truly effect the changes that are needed. But it is an incredibly important one for us in Northern Ireland, and it is key that we provide the strategic leadership and direction in terms of leading the change. And finally, and probably most importantly for me, our success will be achieved through the people involved, their actions, their words, and their deeds. I look forward to the panel discussion this morning and wish you a very, very pleasant and interesting conference. Thank you.
Thank you very much, Sharon. If there is a term or a metaphor that is underlying this session, that is journey. And in the past, we've used different metaphors to refer to this process of providing care, which is person-centered, continuous, and coordinated. But journey has become very, very popular. So in ICIC 22, the term appeared in the program 6 times. In 2023, 8 times, and if you check the program this year, it appears 13 times, and it's been used quite a few already this morning. The journey towards integrated care is not really a wild adventure into the perils of the jungle and the unknown. It's not a pilgrimage to the Holy Land where we are going to rest happily for the rest of our lives. And it's not a climbing expedition, a sort of conquest that we have to make. It might feel sometimes a bit of these things, but it's just a journey, and as a Spanish poet said, se hace camino al andar, so you make it just when you walk it. So we've just heard about the journey in Northern Ireland, and then our next speaker, Rafael Bengoa, is going to present is going to show us or reflect upon different journeys that have been happening across Europe. Rafael Bengoa has been involved in various integrated care journeys internationally, from the Basque Country to Northern Ireland, either inspiring the change, designing the journey, and driving the change, implementing reforms. He's very well known, in particular in this part of the world, and I think he's joining us online. Rafa, buenos días. Are you with?
Buenos días.
Rafa. So Rafa Bengoa is presently the co-director of the Institute for Health and Strategy in Bilbao, Spain, and advises on policy-level reforms to governments worldwide. He was regional minister of health of the Basque Country, vice chairman of the advisory group Horizon 2020 of the European Union, and director of health systems in WHO, where he led the Integrated Care for Chronic Conditions agenda back in 2000. More recently, he has led the expert panel for Northern Ireland, and many of you remember, it was mentioned this morning, that very appealing title, Systems, Not Structures. And he has also participated as expert in the Scottish Digital and Health panel. And the title of his talk is, What Have We Learned from the last 10 years in the journey towards integrated care in Europe? How can this knowledge support system transformation? Rafa, cuando quieras, the floor is yours.
Okay, thank you. I hope you can hear me. The idea is to talk for those 15 minutes, and of course, have the panel react and learn from the panel. First of all, of course, thank you to the organizers of the international conference and to IFIC, Professor Heenan, Dr. Alvarez, Sharon Gallagher, etc. Belfast, of course, is an ideal place to have this conference on integrated care, because I've always thought that if there's somewhere that's going to be able to pull this off after all the people I met there 5 or 6 years ago, will be Northern Ireland. Also, other parts of the UK obviously are on the journey that you mentioned, and there's a tremendous amount of knowledge in different parts of Europe, and that's what I want to be focusing on. The idea, the thing that, of course, we all want to forget is the COVID pandemic we've just had. But I just want to start off with this slide, which basically says we've had the biggest fall in life expectancy in the last 50 years in 204 countries in this Lancet study. I bring this up because obviously we're not going to be able to come back to both lifespan and health span in a constructive way with the present model of care, which is still dominant in most of Europe. What we've been calling the vicious cycle, which is we've had this overwhelmed health system focused on rescue and acute care, with industry-led risk factors and weak public health, primary care, etc. And I won't go into the details of all that, but obviously with COVID, that just got even a bit more vicious. And of course, what IFIC and all these conferences are trying to do is, for the past years, is to get us onto this more virtuous cycle with proactive management of chronic diseases, integrated care, population health, digital health, etc. So it is evident that to get back to this growth trend that you can see here, that this is what was happening until 2016, 2017, it depends on what we do the next few years. And so for those of you developing, of course, integrated care in your countries, it actually means accelerating, I think, the this trend towards both life expectancy and health expectancy. I want to use this short strategic building framework in the following way, just to have a few insights of things that I think are happening around Europe, which is basically everybody trying to achieve strategic clarity while obviously maintaining the values that have built most of the European systems. But at the same time, changing the organization that we all need towards more integrated care. But that clarity is not all over Europe, but it is in sufficient places for us to learn all together. And of course, what is stopping us is not so much this strategic clarity or the organizational clarity, because we know where we're going on that journey, but it's to actually build a management system for change. The common strategic line being followed in all these countries and contain all the words that you're going to be working on during the conference and that we've all shared in the last 10, 20 years. But what's interesting is that very different systems in Europe and elsewhere, they all have the same policy intent. They're all trying to introduce more patient-centered population health, integrated care, new payment models, etc. That implies that the journey is going to be common to many, many countries, although they're of course moving forward in very different ways. If implementation is the problem and what we have to get around it is, of course, context in all those different countries becomes very important. But there are some insights that we can all share together during this panel discussion. It was mentioned before by Sharon Gallagher that we did a report called Systems Not Structures way back with these panel members and with the support of the civil service, etc. The important thing is that we did the easy thing. It took us a while, but we basically knew already at the very end that it was going to be really hard to pull off. But that there were conditions in Northern Ireland to be able to be one of the parts of the world which did pull it off. This framework by Wu and others, I think is useful to think about whether European countries have the capacity to do something so difficult. The analytical capacity, the operational capacity, and the political capacity. And I want to focus a bit more this morning on the political capacity. I think the analytical capacity in Europe is the evidence, the data, the research going on in health service research. The operational capacity, we have fantastic infrastructure in most of Europe, whether it's a health insurance system like Central Europe or an NHS like North and South of Europe. But all of them have a tremendous operational capacity with very powerful and well-prepared healthcare providers. And then the tools that we need to pull this off and that we've heard about before, I think are around and are getting more and more sophisticated. What's important is to identify whether we have the political capacity, the individual political capacity, the organizational political capacity, and the systemic political capacity. And thinking about different parts in Europe where I've been working, that is, I think, where obviously most people are trying to focus their attention. This is from Pettigrew way back. It's almost 30 years old, but I still think it's extremely interesting because he was already focusing on how and not what to change, and basically saying that at the political level, you have to create a receptive context for successful change. And he also mentioned that there's no guarantee, there's no simple recipe or quick fix in managing complex change. But take the journey and start it and learn. David Hunter and I simplified the Pettigrew in some of our work, but basically you see there in purple the importance already being given way back, not only to what policy, what happens in the organization, but obviously to politics and environmental. So both frameworks and even other frameworks that we have obviously all focused on something needs to happen at that level. So what are the obstacles at that level? What's interesting, again, is that they're universal. It's almost a behavior in political cycles to focus on short-termism. And of course, that doesn't help very much. Then we have short-term budgetary cycles, which don't help very much either. And even CEOs in the industries, non-health industries, those that don't undertake reform, it's because it runs against their self-interest. So I think it's important to understand that at the political level, this is also happening in our health systems. What's interesting, though, although all those obstacles are there, many providers are finding ways to innovate locally. And so you're going to be able to see some of those local innovations as you move around. And although they're not a system yet in almost no European country, they will be little by little. So there are obstacles, but we can move forward. How? Well, in Europe, where the policy level has taken the lead in terms of creating a receptive context for adaptive change, it's happening. In such complex environments, a large-scale transformation, of course, everybody understands that needs to be actively managed. It won't happen because our systems, health and social, do not self-organize themselves, so you need to be actively managing. It implies system leaders have to be very tight on outcomes, but loose on the means to achieve them. And of course, allow and learn from local successes and bring them up to and generalize them when they can. This from David Fleming is useful in the sense that this implies that you have to create a top-down framework and allow a lot of bottom-up innovation, a lot of adaptive change, what everybody calls emergent process, but one that fosters local innovation. And those countries that have moved this way are actually further on their journey than others. This implies systems leaders, as I said, to be very tight on outcomes, but loose on the means, and learn from the local success. It also implies a new type of leadership, which has been mentioned already before, and which is essential in integrated care. To understand that it's a collective activity. It is not going to happen with some sort of heroic action by some top-down leader. And just to finalize, all over Europe, there's a common trend, which is this operational disconnection that's happening between management and healthcare professionals, which obviously is not going in the right direction. So what's interesting about integrated care is that those two worlds come together in a much more constructive way in these local provider healthcare, let's say, innovations which are happening at the local level. And we need to be able to get beyond this operational disconnection, because in some countries, it is obviously being one further obstacle as healthcare professionals distance themselves from what we need at the policy level. And lastly, our public NHS systems paradoxically saved the COVID crisis, but are suffering from a latent privatization. This is happening in many European countries. It may be involuntary, it probably is, but it's a dangerous trend, and one needs to obviously restabilize public systems in the next few years. That restabilization implies more funding. Less funding implies less leeway in managing the acute crisis that we've had and future acute crisis. But funding, as I think we can see around Europe, is key, but is not the only lever. We need to identify this top-down, bottom-up adaptive change process, and understand that health systems do not self-organize, that you need some bold policy-level decisions and commitment to move forward. Thank you very much.
Thank you very much, Rafa. I think we all have a lot of questions boiling in our heads, but I want to now invite our panel to reflect upon both presentations, Sharon's presentation and Rafa's presentations. I'm not going to extend on the biographies of the different panelists, because you've got that in the app, but just to say briefly something about them. So starting from the end is Dr. Sarah Barry, and she's Senior Lecturer and Director of Academic Programs at the School of Population Health, RCSI, which stands for Royal College of Surgeons. Sarah. Then I've got Johnny Graham, and he is a service user representative, currently a member of the Consultative Forum at AGE Northern Ireland, and a member of the Mental Health Engagement Platform run by the Patient Client Council for Northern Ireland. And then we've got Dr. Kwamie. She's Unit Head at the Alliance for Health Policy and Systems Research, WHO. So I would like to invite you now to take a couple of minutes just to, or a bit more, to reflect upon what you've heard from both presenters. So if you want to start, Sarah.
Can you hear me? Yeah, okay. Good morning, everybody. And thank you for the invitation to participate in the panel this morning. And thank you for the lovely introductory speeches. In thinking about saying a couple of words this morning, I went back and read Rafael Bengoa's report again. Always a good thing to do. And what I noticed was a lot of very familiar threads from our experience in the Republic of Ireland. So I was quite closely involved with our Oireachtas committee, who produced the Sláintecare report in 2017, so just a little bit after Systems Not Structures. And as an outplay of that, one of the things I was asked to do subsequently around the implementation of Sláintecare was to do a study of reorganisation in the Republic's health and social care system over the last 30 years or so. And one of the key findings was that actually, in some shape or form, we've been trying to do integrated care. Although the language has probably shifted and changed, but we've been trying to do it for quite some time. But that process, that policy process, has been marked by, I suppose you could say, implementation failures, or an inability to actually achieve. And I like using film references, so there was a little bit of a dynamic that we identified, which we call the Back to the Future vortex, where we were kind of, kept trying to work in terms of developing a much more integrated health and social care system, but somehow not achieving that. Now, this was one of the drivers of the Oireachtas committee that worked on the Sláinte Care report and the subsequent drive of implementation. And one of the things that became very, very strong in that report was that the committee were very keen that the implementation of Sláinte Care would be right at the heart of government and therefore placed in the office of the Taoiseach, the Republic's Prime Minister. In subsequent years, that did not happen. The report's recommendation wasn't followed. And in many ways, and this is where I'm picking up on the presentations this morning, the implementation, in a sense of the Sláinte Care as a whole of system process, somewhat stumbled. That's a long story in itself, which I don't have time to go into now. But essentially, we still have an implementation board, but the kind of energy, and maybe slightly controversial in saying this, I wonder, has the policy itself become a little bit siloed and a little bit, sometimes in the parlance, and those of us from the Republic may be familiar with this, you hear, well, that's Sláinte Care, and there's some other reform going on over here. And I suppose this leads me to the last key point I want to make is that I've noticed in Rafa's presentation there that he picked up on political will. Going back to the reorganisation study I did for the department, the lack or the risk of sustained political will we identified as a key challenge, and no surprises there. I absolutely understand that comprehensive whole-of-system transformation is really, really difficult. We're talking about slow, consistent change, as the speakers have highlighted, and systems theory tells us that. It's not only complex, it's also complicated, which I think we've spoken on many. And in a sense, whilst we go to the principles, and I agree with the idea that integrated care, of course, is a sense of direction. It's not an endpoint per se. The principles, often don't match the politics, and there's a real challenge with that. Personally, having a background in organisation science, I'm a real believer in focusing in on the core organisational functions, while accepting the point that we need the political will, leadership, and we need the bottom-up innovation, as the speakers have highlighted. So I'm a real believer in, I suppose what I did like in the going back to systems, not structures, was what I saw there was a real philosophy of working with the system and championing what's happening and what's strong. So on those initial thoughts, I'm going to pass over to, I think it might be Johnny.
Well, I'm probably the oldest person in this room today. I've been around a very long time, born just after the war, and don't really remember rationing and so on. But my wife was a nurse. I have a lot of doctor friends. I've seen a lot of medicine changing, and I've been involved for the last 8 years in trying to deliver integrated care at local level. And I have to say I've had a lot of good experiences from that. But I've been inspired by a number of people. I spent half an hour with Professor Bengoa whenever I joined the Integrated Care Partnership in Lisburn, telling us what it was all about. I've been inspired by Mark Taylor and Alan Stout, who were both on that group, who worked with Professor Bengoa to give us the framework. And I'm convinced that framework is the right framework. The point that immediately came to my mind from Professor Bengoa's talk was strategic clarity. And in my early days as a member of the Integrated Care Partnership, despite all my pals and my wife telling me all these stories of when she was a district nurse or a nurse in children's and all this sort of stuff, I didn't really understand what integrated care was all about. I had a superficial grasp of the issues. And after a year or two, I was a bit better at it, but I never really grasped it properly till I was invited to sit on a group which were trying to address health inequalities in Lisburn. And we had the police, we had social workers, we had the one who completely knocked me out was a speech therapist. I sat with her for 20 minutes and told me of the problems of children under the age of 5 if they can't speak, articulate, have conversations. And that was the moment when integrated care really started to mean something to me in a way that I felt I could make more of a contribution that I had already been doing. So I think my big point is that we need to get this message across. The average man on the street, woman on the street, doesn't really understand it, and I suspect that there's a fair proportion of the health service staff don't really grasp it properly. So my thinking is that one of the big things that we have to do, and we've got a very good framework which is being developed here. I've had some really good experiences of co-design recently, but the one bit that gets me is to get this strategic clarity, and I think we have the people here who can do that. The minister gave a very interesting talk, so did Sharon, and I think that the few doctors that we have who have already bought into this have a real role to play to get this message across. This is what we're trying to achieve, and I think we can and will achieve it.
Well, good morning, colleagues. It's a privilege to be here this morning. I wanted to thank the organizers for the invitation and a very fortuitous meeting with Dr. Lennox Chugani in Costa Rica, which shows the power of overlapping networks, and I'm grateful to be on this esteemed panel this morning. I want to make just 2 brief comments and picking up on the comments that have been made by the presenters on complexity. But before I do that, I did just want to say that the team that I work with at WHO, we're a very small unit, and we have a mandate to use health policy and systems research in low and middle income countries to strengthen health systems. And so that's the perspective from which I'm speaking this morning. And I think just picking up on this motif of journey, when we think about the integration care journey in high income countries as compared to the journey in low and middle income countries, we see that the starting positions were a little bit different, that in many high income settings, the considerations were really around patient experience and clinical pathways and multidisciplinary teams, whereas in low and middle income countries, the preoccupations were really around trying to integrate vertical programs, communicable disease programs like HIV, TB, malaria, maternal and newborn child health care challenges, how to integrate those into primary care. And yet, even though the starting points of this journey on integration care have been different, I think that in all settings, the health systems have come to an inflection point. When we look at the kind of challenges that are facing health systems today, they are universal, and I think that comment has been made already. So when the next pandemic hits, it's going to hit all health systems. When climate change begins to affect how we deliver health and social care services and the kinds of health issues that present, that's going to affect all countries. When we think about generative AI and what that means for social services and human resources, that will affect all countries. And so I think that just in terms of lessons that we want to learn in both high-income country settings, but also in low and middle-income country settings, that inflection point is that in order to think about what are the systemic transformations that are required, health systems and health and social systems in those countries really are coming to that inflection point together. The second point that I wanted to make very briefly was about complexity, and I think it's quite interesting because in the past few years, I've had a reflection. So I'm interested in complexity theory and how we apply it to health systems governance. And one of the reflections that I have had is around some of the assumptions that we make when it comes to complexity. Public health broadly and global health also has generally use one type of approach when it comes to complexity, which is that we understand the dynamism of multiple actors, multiple levels, multiple interventions, and we try to model their interactions. We try to come up with best practices. And yet there's another approach to complexity, or another set of assumptions that we make around it, which is really about how do we understand how the part relates to the whole and how both are changing as they interact with each other over time. And the reason why I bring that up in the context of this conversation of integrated care is because it seems to me that if we take that approach, it helps us think differently about how we measure integrated care. And so trying to understand and recognize the properties of complex systems, whether it's emergence, whether we've heard a little bit about this morning, whether it's path dependence, whether it's self-organization. And so trying to think of, well, how are the various interventions that we're putting in place actually yielding emergence? What emerges when particular conditions are in place? What are the path-dependent lessons that we can learn that if you start down this track, for good or for worse, you can't come back? And when we begin to document the systemic changes in this way, it helps us to move to, I think I would add a third arrow to our title of our plenary this morning. So from evidence to policy, and from policy to practice, but then also from practice to evidence, and that we need to get better at actually documenting what is already happening within the system so that we can systematize those lessons and learn from those lessons as well.
Thank you. There's a lot of food for thought there. I don't know whether we're going to actually ask you some questions on that. I think I'd just like, before I hand back to Sharon, who might want to have a response, I just wanted to reflect on Rafa's comments. First of all, to say it's great to see him back here. He is held in very high esteem by academics, clinicians, and that in itself is fairly unusual because people believe that he came with a vision. But I was really interested in what he talked about in terms of obstacles, and they are universal obstacles. So sometimes in Northern Ireland particularly, as we are apparently the most studied part of the world, for obvious reasons, we kind of are very inward looking and believe that our problems do not exist elsewhere, and in fact sometimes are even loath to look across the island to learn what's happening with Sláinte Care, for example. But he talked about political cycles, budgetary cycles, and self-interest, and a political system that really does not fit well with changing healthcare systems for all the reasons that we know. And last year we just published a book on devolution across the UK, and what really came out is we are very poor at learning from each other. So we have this system, we believe we're stuck with it. Why are we stuck with it? Because if it isn't working, then surely there comes a point where you say, it's time to think about this from a different perspective. And increasingly, as I speak to Northern Ireland, they're saying we have got to have a step away from the political process where those obstacles are. Because when Rafa came here, he talked so eloquently about the Basque region and the fact that there was a political consensus that change must happen. And that's why change happened. We are not as fortunate as that. We don't have that political consensus, or at least we have a political consensus until you lift the hood and look underneath it and you find it really doesn't exist. And I suppose then we've got to ask ourselves, if the system we have doesn't work, why couldn't we think about moving to a new system that might give us arm's length from politicians, that might allow us to have some accountability, that might allow more transparency, but actually may allow experts and people on the ground to work together to get on with it. Of course, health is political. It would be very naive of me to say it isn't. But you can have a model that allows political oversight without political interference. And I think in Northern Ireland, after 26 years of a devolved government that has been disastrous for our health and social care system, we really have to think about new models and how we're doing it. And interestingly, of course, Rafa talked about systems, not structures. And Sharon gave a very interesting talk about what's happening in terms of integration. But I suppose handing over to Sharon, the person on the street doesn't really understand why we're having more systems in a process that looks like it's got an awful lot of systems that already exist. And the other question is, if these new groups have no power, have no budget, have no commissioning, then I suppose people are going to roll their eyes and say, what is the point of this? It's another layer away from money, away from the coalface, as it were. So I suppose I would just be interested to get more of a discussion about, if they don't have the powers that we understand where decision making lies, then is it more bureaucracy at a time when we should actually be thinking about stripping it away? Sorry, Sharon.
Thanks, Deirdre. There's a lot of questions in there, so I'm going to have to be a bit careful which ones I respond to. I guess to take the point that you made, that we look at Northern Ireland through our own set of eyes, our own hilltop, I think that's right for all of us in all places that we live. But I think we need to do that in order to understand the art of the possible. So I have been involved in this work from, see Rafa on screen now, right back to when Rafa was here, 2015. I jointly put together the response to that, Delivering Together, which at that time was a 10-year framework. So back in 2015-16, we believed that in 10 years we could make a significant change. But we understood the risks to that, and to my colleagues' points earlier, one of those was political, financial, and resource. So we had executive commitment to our document 10 years ago, and indeed we still do. Transformation is a shared ambition by politicians and by I think, the population of Northern Ireland. What isn't altogether clear is, what does that mean? Because when you ask any of us within Northern Ireland, what does transformation mean for you, they will say something different. And therein lies the complexity, therein lies the problem. So we have an agenda. In speaking today, I set out how we have moved forward in that agenda. ICSNI is not another system. It's not another bureaucratic piece of infrastructure. In fact, it strips some of that back. But why we call it a framework or a culture rather than a process is because the points that I make about people working together to collaborate, to bring resource together, human resource, political resource, financial resource, enables change. And that is something that we need to provide system leadership on, both at political level, but from all of our perspectives. And as Johnny, I think, said, the best evidence of that is at local level, where people have no option but to come together, share resource, and make the best of it. And I think looking at some of the local initiatives that you will hear about and have the opportunity to go and visit gives us our best, I suppose, illustration of how change can be affected. So just in closing, because I know others will want to say something, maybe pick up on this, I can't say that in 5 years things are going to be significantly better. We have a demand capacity crisis right across the world. It is something that that challenges us every day. We understand that we need money, we understand we need political leadership, we understand we need staff working within the system. But the points that have been made in terms of bringing people with us, demonstrating and showing what transformation really means, that's where leadership really comes to play. Because population health is not about a hospital at the end of every street. It is not about one sector versus another. It is how, looking at pulling all of the resource together, we better meet the needs of the population. And that's what the ICSNI framework enables us to do in Northern Ireland.
Thank you very much. Can I invite you, Rafa, to join and say a few words or reflecting on what you've heard?
Well, the word meaning came up 3 or 4 times. You just see, yeah, I have it on. The meaning of integrated care. I think it's true that if as was mentioned, if the population doesn't get it, maybe politicians aren't getting it either. So what we chose what we chose in the Basque Country, and I think in other parts of Spain and other parts of the world, I think, is to make sure it connects with the patients. And so we turned integrated care into a strategy for chronic care. So that, I think, people understand that it's related to their lives because they are chronic patients. And since just about everybody is going to be a chronic patient, it's reasonable to think that the effort should be to try to use language which connects, because maybe just to say it in another word, in another way, now I would not be choosing, or we would not be choosing the idea of systems, not structures, because that again is too far away from the patient. We would need to identify something in the title and in the policy effort which is related to patients and to their lives. So I think that's probably the only comment I would make. It's about meaning, but maybe somehow that can be linked into the word integrated care somehow, because otherwise integrated care is something we want because we're in the world of organizational development and leadership and all this stuff. But the patient, we need to get on that policy journey. If that's necessary, then we need to be able to use different words.
Thank you, Rafa. It's always, well, we are interested in your insights because you are the godfather of this and you have led us down this road, and we want to make these changes. It's interesting that you talk about language and how you wouldn't have used that language. Last week I was with a group of social workers in the northern region, fantastic individuals, and they also made me aware that there are some words in health and social care that make you go, not quite sure about that word. And actually one that was quite interesting to me was transformation. Look it up in the dictionary. It's rapid change happening at pace. We have been talking about transformation for at least 12 years here. I don't really think that's transformation. So I think it is not surprising that the public don't understand and get a glazed look when we start talking about transformation. So I fundamentally agree with you that we must bring the public with us, and they must accept that change will be good for them. I don't think they want a hospital at the end of every road, but what they do want is access to care in a timely fashion when they need it and when their family needs it. And on that note, I've finished at that. Thank you very much.
I think we still have 1 minute, and actually I want to reflect on something that Niamh Lennox-Chugani said at the beginning, is when we get there, so how do we know that we got there, that we got into integrated care? And I want to give that last minute to Johnny, because he told me he had a story to tell about a butterfly. So please, Johnny.
Picking up what Deirdre just said, I've been thinking about this for the last few days. What motivates me? Outcomes, well, yeah, a whole lot of outcomes, and they're pie in the sky, apple pie and motherhood and all this sort of stuff. But I think, and I do a lot of work with a local organisation in a deprived area of Lisburn, and I hear story after story after story. And let me tell you about a fictitious person, a single parent, 4 children, struggling to make ends meet. They have a younger child with autism. Really difficult that can be, because they're not yet registered to get all the care that you're supposed to get. It takes quite a while to get that. They've got some teenagers in the house now. Those of you who have had teenagers will know what that means. So it's a really difficult time. She's living in a cold, damp house, which is just about the worst thing that you can have in terms of chest infections. How many extra ailments will that family get because of the housing? There's probably an abusive partner, ex-husband, wife, living up the road, banging on the door whenever he gets a few on board on a Saturday night. That woman has inevitably got mental health issues, perhaps not a diagnosed condition that a psychiatrist would give you, but I suffered from anxiety as a result of COVID. I know what we're talking about here, and you go into a spiral of despair. So there are a lot of those people out there now. What I want to see in 10 years' time, well, the one big concrete thing I want to see is I want to see her in good housing in a home that is easy to heat. And with all we're trying to do nowadays with the environment and so on, surely we ought to be able to produce housing with solar panels, and it is 10 years away. I know this might be take us 20. And what do I want for her? I want for her or him to feel the system it's doing its best to meet his or her needs. And the key is listening to her. She or he needs to be heard. That's what we all want.
And we are closing the first plenary. Thank you very much.